Ladies and gentlemen, I'm delighted to be chairing this webinar with a friend and colleague, Will Monaghan, who I've now known for 14 years. We first met when he came to Nottingham as a wee boy in the health service, working as a support business manager in musculoskeletal diseases in Nottingham at Nottingham University Hospitals. He then became the business manager, and he may not remember it, but he supported me when I set up a virtual clinic for shoulder problems in 2011. And then, as a result of the work that was done by Paul Shipwright and Peter James, we developed something called the Nottingham Elective Orthopaedic Service. And this was a relatively new concept. It was a great development. We had a unit built that allowed patients to come in quickly in the morning, prepare themselves for theatre, go to theatre, and then get discharged from the unit. It was very efficient, and Will was instrumental in that happening together with his consultant orthopaedic surgical colleagues. We submitted that for the Health Service Journal Prize, and clearly the judges were not the best judges because we didn't win it, but we were very proud to go down to London, demonstrate what we had done at the time in 2015, and Will was part of that team. Well, he's gone on to do great things, working afterwards in Leicester, then going to Derby and Burton, and now he's gone back to Northampton and Leicester. And I'm going to hand over to Will, because he's going to tell us what he hopes to do in Northampton and Leicester, what he intends to happen over the next 5 years, but he's also going to tell us about some of the problems, he may even mention disasters that have occurred on the way. So, Will, I'm delighted you've agreed to talk to us. I'm going to hand over to you. Thanks very much indeed for joining us.
Thanks, Prof. And you were always ahead of your time, and I'm sure UK DHC will also continue to be evidence of you being ahead of your time. So thanks so much for the privilege of being able to speak to you all today. It's genuinely one of the most exciting things I think happening in health tech in the NHS at the moment is all of the efforts that you guys are putting into making it easier and safer for people to deliver care and easier and safer for patients to receive care. So I'm incredibly honoured to be with you today. Now, as is always the way, I have a few slides. So if you'll bear with me, let me pull them up and then go into the display mode. And then hopefully, Prof, you can give me the thumbs up if that's working properly. Great. Thank you so much. So I thought it'd be interesting today for us to talk about whether we think it's been easier and safer to deliver care over the last 10 years. And if it's not been, then what's our hope for the next 10 years? So as Prof's already given you a little bit of background about me across UHL, University Hospitals of Leicester, and University Hospitals of Northamptonshire, we serve a population of about 2 million. We have about 2,500 inpatient beds. We have about 30,000 staff across UHL and UHL, and we spend an enormous amount of money on delivering that care. We spend 2.4 billion across the group on the delivery of healthcare every year. Now, lots of you will be familiar with the scale and size and complexity of the NHS as a whole, but I often think it's worth us zooming out so that we recognise the massive impact that technology can play across an organisation of our size and complexity. So the NHS, as of last year, cost 181.7 billion to run, employed 1.3 million staff. That's an enormous opportunity for us to get something right or for us to get something wrong. the critical thing for all of us is that we manage to get more things right than we do wrong. And one of our major challenges has been the role that digital has played in that work. So I want to talk to you about a little bit of the history of digital transformation across the NHS. So we started with the National Programme for IT. That's probably the biggest example of a massive attempt at digitisation across the NHS. We spent around 10 billion in trying to digitise the NHS. It's often cited as the main case study for programme management failure for governments across the world. And then we had care.data, which was about transforming the way we use data. That collapsed largely due to public trust issues. Lots of good people working on it, just like the National Programme for IT, but kind of failed in that regard. We've then had a couple of examples. Some of them have gone better than others. We're starting to see real progress from frontline digitization, but we're far away from where we want it to be. So we've had countless local digital transformations and we've had variable attempts, and yet somehow we've managed to make it harder to be a clinician in the NHS, not easier. When I think about that, I think about all of our investment, all of our innovation, all of our good intention, and we've created a system where skilled healthcare professionals spend more time serving technology than technology spends serving them. That's quite an achievement and not one that we can be proud of. I just wanted to kind of paint a picture of our current reality at UHL and UHN, and I'm sure it's replicated in lots of NHS organisations across the country. We have a kind of fundamental problem, which is a massive credibility gap between digital teams and frontline clinical staff. For example, in our maternity unit, midwives are documenting the same information in 3 different systems because they all require slightly different versions of the same data. In our intensive care unit at UHL, we deliver ECMO, which is some of the most advanced technology, clinical technology anywhere in the NHS. And in that environment, our nurses still manually copy vital signs from monitors onto paper. In our pre-op assessment unit, we still require our clinicians to log into 4 different systems, each with a different password, different interfaces, and different ways of recording essentially the same information. If we zoom out and think about, well, what's the impact of that? Well, studies now show that clinicians spend a significant amount of their time at work on administration rather than care. Just thinking about that, in an age of unprecedented technological capability, we've created a system where, depending on which study you look at, but they sort of all coalesce around a reasonable number, nurses spend about 35% of their time on documenting rather than on delivering patient care. We evaluated the time our doctors in training spent on screen and on the phone compared to with patients and learning from senior clinicians. It was almost twice as much time on the phone and on screens than learning and being with patients. And that's especially the case in the early years. And the consultant colleagues that I talk to consistently refer to the need to cross-reference multiple systems to give care. And the safety impact of this activity and the sort of feeling of what it's like to be at work for those clinicians is staggering. Our clinical teams often talk to me about the sense of frustration at the mismatch between the speed that they can think and the speed they can act on the systems. They talk about missing crucial information because it's, again, buried in multiple systems, and feeling professionally compromised because they're spending more time on data entry than they are on patient care. The other aspect is, and I don't know, this may ring true for lots of people on our webinar this evening, the need to develop workarounds just to get through the day. And in the process of developing workarounds and trying to make the system work for you, not only does that introduce new safety risks, but it also makes people feel personally and professionally at risk because they haven't followed the process exactly as it's set out. So why bother then? If you had a kind of time traveler from 100 years ago and deposited him in an outpatient clinic in one of our hospitals, could he really tell the difference between the type of care that he receives now and he would have done 100 years ago? Surely there will be some more screens around, but essentially the model of care is almost exactly the same. So why not then just stay as we are? Well, my answer to that is we can't if you care about patient safety, and we can't if you care about what it feels like to deliver care in our services. So we can't go back. So we have to go forward in the right way. And I think for me, fundamentally, the missing links between kind of our digital innovation and making it fun and interesting and good to be a clinician in our NHS again aren't technological. They're mostly human. And the first and most important is about fundamentally changing how we design and implement technology. So if you live and work in the UK, you'll have noticed that over the last 10 years, the UK government, which has got some things wrong, I guess it's fair to say, has completely redesigned the way citizens interact with it through the development of gov.uk. It's now many orders of magnitude easier to get a passport, renew your car tax, register a birth. And they started with a single overriding principle. You weren't going to have your own website for everything. Everything was going to be done in a standard way. And that overriding principle was starting with user needs. Being able to design around user needs is absolutely critical. I personally think I'm very easy to deal with. And because we've got nobody else on the webinar that works with me, let's just assume for the moment that that's true. But one of the things that I am a difficult person about is that I insist that all of my senior team and everybody in the digital data services across UHL and UHN spends time every month with clinical teams watching them use our systems, not in meetings with them, not in workshops with them, but on the wards, in theatres and in clinics. And this changes everything about what gets built. When you've stood for hours, like I have, watching somebody navigate through 8 clicks to do something they need to do 50 times a day, you design that service differently. When you've seen the frustration of a junior doctor trying to find crucial information spread across multiple systems at 3 a.m., you build differently. With the permission of both the patient and the oncologist, I was sat in a clinic a few weeks ago, and having spoken to the patient beforehand, asking for her permission, I learned that she had children the same age as mine. And I was in that room as the oncologist delivered the incredibly difficult news about the prognosis for that lady. And in that moment, when all of his attention, all of his care should have been focused on that acutely difficult interaction, I saw him struggling to pull up the letters from the referring centres, saw him struggling to get the images side by side on the computer screen. You only have to go through that experience once for it to fundamentally change what you do. And we're seeing the impact already of putting clinical users at the heart of the decision-making process. Our clinical teams aren't just consultees in the new electronic patient record implementation. They're designers, they're testers, they're champions. They're running the sessions, they're making the decisions, and they're shaping the workflow. And the result is that now our clinical teams are actively chasing us for the technology. They're pushing us to go faster. And more importantly, they've started to tell us that it feels like someone's starting to listen. That can't be the whole answer, though. And we've decided that it's not good enough for one organization to be able to tell a story about how it's putting users at the heart of its technology. But instead, what we're trying to do is create a group of acute hospitals across the East Midlands that are coming together with a single vision around technology to make it easier and safer to deliver care across the NHS. We're starting to work together on Nerve Centre as our single platform and making it possible for colleagues across the East Midlands to work in any one of our organisations. We brought together the clinicians from those, senior clinicians from those organisations, in the hope of being able to describe a clear vision for what we're aiming to deliver together. So this is our vision as we've set it out across our EPR. We've made up of a core group of people, so lots of different leadership positions across the 5 trusts. And we've got a good spread of disciplines as well. So what we're trying to do is to bring clinical and digital people together to make decisions on a shared platform that will allow us to realize far more digital transformation than if we were to all plow our individual furrows. If we hadn't done this, we would all be competing for the same set of resources. If we hadn't done this, we will end up designing 5 different solutions to the same set of problems.
Will, can I stop you for a minute
Yeah.
on that slide? Can you just go back? Because the headings, Chesterfield Royal Hospital, Nottingham...
Sorry, yes. So Hospital. Chesterfield Royal Hospital, Nottingham University Hospital, Nottingham General Hospital, University Hospitals of Leicester and University Hospitals of Derby and Burton. And as of last week, we are also joined by United Lincolnshire Hospital Trusts and Kettering General Hospital and Sherwood Forest Hospital are the other 2 acute providers in the East Midlands. They are currently going through their EPR procurements, and we feel very optimistic that they will end up choosing Nerve Centre as well. So we will end up having all 7 of the kind of acute providers across the East Midlands, hopefully on the same platform.
And if I can do a minor correction, you did say NGH was Nottingham General Hospital.
Sorry, Northampton General Hospital. Yeah, thank you, Prof. Yeah.
Over to you.
Nothing on the brain, thanks. So we, as you can see from this slide, we look at a lot of opportunities to bring things together, whether that's NHS England on the bottom left doing all of their assurance for the product. Instead of doing that 5 or 7 times, they're doing it once through a single place. Instead of us all coming up with our own way of doing subject access requests, we're doing that once and then sharing it out across all of the trusts in the East Midlands. And we're doing everything we can to try and make the clinical experience of delivering care the same across all of the East Midlands as well. And not only that, I touched on this very briefly, but we're trying to make that collaboration far more radical. So it costs currently millions and millions of pounds to do digital transformation in the NHS, largely because we're reliant on very expensive consultancies and resources from the market to deliver it. We believe there is a better way of doing it. We believe that you can gather people together across the East Midlands to work for the NHS and be deployed anywhere in the East Midlands. So we've started working on this concept of parachute teams. The first one is that we've gone live with is our training team. As lots of you will know, because you're interested in this area, when you let a contract with a big supplier like Nerve Centre, you get a certain number of days of training. So you might get 3 days across 3 occasions. So you might get 9 days in total of training on the product. Now, it's almost impossible to schedule a meeting with 9 people, let alone try and train everybody across 9 days in an organization. So instead of doing that, what we've done is pooled all of our resources together and created a kind of always on training capability. So we've recruited some people centrally rather than each trust having their own training team. And we're providing training. So when you come to the training for Nerve Centre, it won't matter if you're from Northampton or from Chesterfield, you'll be side by side with people learning exactly the same product in exactly the same way. That makes a massive difference to our ability to offer really good training to everybody across the East Midlands. And we can pick our staff from various different places. So some of them are trust staff, some of them are people we'll get from the market, and some of them are people that have been recruited to Chesterfield Royal Hospital's wholly owned subsidiary, which is DSFS. So the goal here is to make it easier for every deployment to go really, really well across the entire NHS. We recently did a deployment about 6 weeks ago in Nottingham. We had floor walkers and teams from Derby and Burton, from Chesterfield, from Leicester, and from Northampton all go to Nottingham to deliver that change for them. But that's not enough. So us getting to the stage where we've got really good implementations of our current EPR is not going to be enough to give us hope about where we go over the next 10 years. So we can do a really good deployment of the EPR, but if we don't fundamentally change how we record care, all we're doing is asking people to update a better system. Sorry, is my screen sharing working? It came up. It is working. Okay. Okay. So we have to change fundamentally the way we are doing documentation. So documentation has become a kind of proxy for caring. I've documented an episode of care and therefore I have cared. And often the reality is anything but. The documentation is getting in the way of people being able to do the caring. So if we think about what's happening in a theatre in the NHS right now, we have staff manually recording when a patient was sent for, when they arrived, when the anaesthesia started, which drugs were used in the anaesthesia, when the timeout was completed, and when the procedure began and when it ended. Each of these actions are ones that could and should automatically create their own digital footprint. The act of sending for a patient should create the record, moving them should update their location. Delivering care should document itself. And we're starting to see that change in really small ways. In our emergency department at the Leicester Royal Infirmary, we now have a number of areas where observations flow automatically from the monitors into our electronic patient record. No transcription, no delay, no opportunity for error. And time created to allow people to do the job they thought they were coming to do. And the teams are now so much happier because of it. And when we started, there was some nervousness about the decision-making process. Does writing it down make me think about it more? But we found that actually giving people time is giving them space to make professional judgments on the care. The next shift I think we collectively need to make if we're going to make the next 10 years any better is making data work for the people delivering care, not just for management reports. People will have seen a kind of landmark report from the NHS that was called Data Saves Lives. And it's true. The more access we can give to people directly involved in the care of their patients, about their patients, the easier it is to understand where we can improve. Digitizing healthcare processes allows for unprecedented tracking and analysis of clinical interventions. Unlike the traditional paper-based methods, digital systems can provide real-time data on patient outcomes, medication administration, and adherence to clinical guidelines. This is a huge amount of information that creates a robust platform for us to make improvements on. And what is perhaps more exciting than that is that the data collected through those systems can feed into artificial intelligence algorithms, enabling identifications of patterns and potential risks that could be invisible to the human eye. I'm sure we've all seen some of the really exciting stuff happening in the US, where AI is beginning to be used to flag unusual trends in patients' vital signs or unexpected interactions between medicines, alerting clinicians to potential issues long before they become critical. And we're in the foothills of what's possible. We've already started to use AI and automation to reduce some of the burden on our teams. But every automation, every algorithm has to be designed to augment and support clinical decision-making, not replace it. And the breakthrough in the use of data will come when teams can understand and use their own data, not for reports, not for targets, but for improving care. When patterns emerge that help us prevent readmissions, when trends show where we can intervene earlier, where data helps predict and prevent rather than just record and report. And that means we have to kind of democratize the access to the data. We've often said that knowledge is power. I think in the NHS, it would be more true to say access to data is power. And we've seen that across the last 15 years. If we can get data in the hands of more people and get data skills in the hands of more people, we'll be in a far better place. So where do we begin on this journey as to what's next and where we're going to make progress beyond just getting the EPR right by doing it together? When I took on this role 12 weeks ago, a senior nurse told me something I'll never forget. She said, "Will, I don't need artificial intelligence. I need my computer to log in less than 10 minutes. I need the system to not crash when I'm documenting medications. And I need a help desk whose job it is to actually help me." And she was absolutely right. So in both our hospital groups, we're starting with the basics, moving to modern and reliable infrastructure, creating a single help desk that focuses on genuinely helping people, getting devices that works, and perhaps most importantly, making passwords manageable through the use of Improvata's single sign-on technology. But we've started to see, and look, it's really early days. And if you work in UHN or UHL, you'll agree with me here that it's early days. We're starting to see teams beginning to trust us again, and they're beginning to maybe believe that digital could actually make things better for them. And this brings us probably to the most important part of this whole thing, and exactly why it's so exciting to be with all of you here. Because the most crucial element in changing all of this is putting clinicians in charge of digital transformation. In both our trusts, we've majored on over the last 12 weeks, creating clinical digital teams, doctors, nurses, and other healthcare professionals who both understand the clinical and digital worlds. Their role isn't about necessarily just implementing the systems. They're the voice of the user to us and our voice to that user community. They are the most important roles in the whole organization for us. And we are in the process of trying to gather the grumpiest group of clinicians we can find to sit on our reference group. We want them to be the ones that are checking our work and are saying when it's actually ready to be deployed into the system. We know if as a team we can win them round, it'll be ready for the rest of the user groups. And I think the centrality of that clinical voice matters even more when we think about emerging technology. When we think about the use of EPRs now, it's largely about input of information and joining it up across the clinical pathway. We've focused on delivering that, but the next generation of technology could be genuinely exciting. It could go from being something that we have to input to something that's helping people to make decisions, that's surfacing all of that information already. We've seen 2 advances in areas, and we're looking for lots of more opportunities to do that. So we worked with a spin out from a university in Scotland that ingested all of our clinical guidelines that we open source for everybody. It then trained an AI model on those clinical guidelines. And now we have, in a small trial, some of our junior doctors able to talk in natural language to those clinical guidelines, to ask questions of the clinical guidelines, to get answers back in natural language, and crucially, to find the reference point where the AI has picked up the answer from so that they can absolutely check it for themselves. We've started to see the use of automation in back office functions to make it easier to join and leave the NHS. Perhaps one of the most painful things we've invented as a society is to join a new hospital. The amount of times that you have to enter the same information is mind-boggling, but we've already started to see improvements in that area. And the final one that we are looking at all the time at the moment is the use of AI in clinical care. So lots of colleagues will be familiar with Heidi and the work that that system does on identifying information from interactions between the patient and the clinician that are relevant to the record. And we've started again in a very small trial looking at AI to create discharge summaries. In the area that we've looked at, we reduced the amount of time a junior doctor was spending writing discharge summaries by 5 hours across one shift. This could be this could create a fundamental shift in how care is delivered across the NHS if we get it right. And if we have to do it now, because the reality is I spend a lot of my time out with people delivering care, and the next generation of junior doctors and nurses in training and people across the ward are already using AI to deliver care. They're just not doing it in a safe and regulated way. So we have to get on with this now. This is the moment for us to make it happen. So I'm imagining 10 years out, a future where clinical systems anticipate needs rather than creating barriers. Documentation happens naturally as care is delivered. Data serves the people delivering care, not just those measuring it. And clinicians shape the digital future of healthcare. And this isn't a utopian vision. We have the technology, we have the expertise, we have the commitment largely from our clinical colleagues. What we need now is the courage to admit what isn't working and the determination to fix it. Because ultimately, this isn't about technology. It's about giving time back to care. It's about letting our colleagues be clinicians first and data clerks never. It's about making technology serve healthcare and not the other way around. And if we get that right, I'm really hopeful about the next 10 years. Thanks.
Will, that was a wonderful presentation. I'm in awe of how much you have included in that presentation. Brilliant. What I'd like to discuss with you is a number of points that came up there. You talked about integrating systems. One of the really successful systems that have been developed in maternity units is the BadgerNet system.
Yeah.
Now, you may not realize it, but I worked with Peter Badger when I was Dean of the Faculty of Health Informatics in Edinburgh, because he is Edinburgh-based.
Yeah.
And that development was created up in Edinburgh, and that has now gone UK-wide.
Yeah.
And that is a method of monitoring babies in cots and communicating when babies are getting into problems and what. But there has been an issue of that being integrated into what is happening in the rest of the hospital.
Yeah.
How have you mastered that? Because that can be an issue.
Yeah, it's a real challenge, and it's a great question. And we introduced BadgerNet in Derby and Burton just before I left to come to Leicester and Northampton, and you won't be surprised to hear that we've got a rollout plan for BadgerNet at both Leicester and Northamptonshire, because it's fundamentally a great system. So I think there are two things, Prof, on that. So the first is lots of systems now are operating to a set of agreed standards. So it was previously the case that if you wanted system A to talk to system B, you had to build a bespoke interface to allow that to happen. Now what we're seeing is modern systems like Nerve Center and BadgerNet have got internet standard APIs and FHIR compliant messaging solutions that allow those two systems to talk to each other. Now that's fine when you're doing what we're doing, which is implementing two systems new and asking them to talk to each other. That's relatively easy. What's really difficult is implementing a new system like BadgerNet and trying to make it backwards compatible with an old style EPR, which is why, in part, there's the bill going through Parliament at the moment, which sets out a requirement on suppliers to meet specific sets of digital standards. And that's, again, something that should cause us hope for the next 10 years, but is in part why I think it's been so difficult for systems, and especially for clinicians trying to use the systems over the last 10 years.
Now, UKDHC is a non-partisan organisation, and we support the other electronic patient record systems as well. And I need to point that out at this webinar because
we've been giving Nerve Centre a lot of plugs, or I have at least. Yeah,
you've had an opportunity to advertise, but there are other electronic patient records which are in the system, and I do have to say that some of them are more advanced, some of them are less advanced. I think what you were trying to tell us was that you believe that Nerve Centre is more integrated than the others.
So I think
is that a correct interpretation?
Yeah, I think I would say two things about that, Prof. I would say the first is lots of EPRs that are in the NHS at the moment are on legacy architecture, so they're built in a legacy way, whereas Nerve Centre, and there are others in the market at the moment, are modern EPRs. The other thing I would say is the frustration that lots of people experience with their EPR provider is largely because they were built from the ground up to be billing systems rather than care delivery systems. And I think that fundamentally changes the way you interact with the system, whereas Nerve Centre is built from the ground up to be a clinical delivery system. But I'm not paid by Nerve Centre, though after this session, perhaps they'll decide they should.
Right. I would also like to pick up on another thing where the NHS should have been further ahead, but you will remember that we became aware in the NHS of the problem of staff moving from one hospital to another.
Yeah.
And we decided that we should have NHS passports for staff.
Yeah.
Now, people have worked on that for 15 years.
Yeah.
Is that working? Has it happened? Because that was a logical thing, that one hospital would vet a member of staff, make sure that member of staff was competent, safe, suitably qualified, and then they would get their NHS staff passport to move and work in another hospital.
Yeah.
Is that happening today?
So it's happening in pockets, I think it's fair to say. So there are definitely organisations where that staff passport technology has been proven to work and is working effectively. But as is so often the case across the NHS, getting a couple of people to recognise the thing and make the technology work is pretty easy. Getting 5 or 6 to do it is quite hard, but still doable. Trying to get 146 acute organisations to do it has proved almost impossible. I think if they're serious about Wes Streeting describes this shift from analog to digital, if there's any hope in that, it has to come with the ability for the centre to enforce things like this on local trusts. And I say that as somebody who leads a local trust, that there are times when actually it would be far better for the NHS to act as a single organisation and to require people to do some things rather than give them discretion to do it.
One of the things that I have been frustrated by is the need for the companies that are developing med tech equipment and med tech solutions to have each of these bits of equipment or solutions assessed by each hospital group. And I would love to see an opportunity for us to have medtech passports as well as staff passports. Doesn't that make sense? And if it does make sense, why hadn't we done it? You worked for NHS Digital for a while, that wonderful organisation that was trying to push in that direction.
Yeah. So it does make sense. I think We have started to do that across the East Midlands already. So recognizing that we can't solve it, we haven't been able as a group of leaders in the East Midlands to solve it nationally. So we've started to solve it locally. So we have made decisions around the data privacy impact assessments. We can do that once, and we will reuse that across all of our acute providers. We will do the clinical safety reviews once and use multiple times across all of these Midlands providers. I guess, and maybe it's the same in when you're working clinically. I think there is a fear that we have created a bit of defensive practice in digital. Everybody wants to get their own team to have a look under the hood to make sure it is safe and that the person down the road hasn't missed anything. But I also think, and again, this is in part why UK DHC is so exciting, is because we've probably overcomplicated the differences between our organisations and overemphasised the differences rather than the similarities. And I think it's bodies like UK DHC that can talk with authority to both NHS England and to suppliers that can actually make some of these things happen. So I'm excited, Prof, to see where this goes in the next couple of years.
And in relation to UK DHC, the thing that we have picked up is that the frontline workers in both healthcare and in social care and in care homes are struggling with developing their skills to use the technology that they are being presented with. Yeah. And one of the drives that UK DHC is making is to help those at the coalface self-assess themselves, find out what they are good at and what they need improvement at. And we are bringing out in the new year self-assessment projects so that individuals on the front line in the NHS can assess themselves and decide how they can improve their skills where they have problems. And it may simply be using iPads, it may be which button do I press? Some of us are very aware that our grandchildren are far more skilled than we are at doing a number of these tasks. And so we at UK DHC want to actually help the NHS in improving their interface with the technology that you are developing through, for instance, Nerve Centre. And any help that you can give us would really be appreciated from that point of view.
Of course. I think there's two things I'd say on that. So I think that you're absolutely right, and it's really important work. I think often people have digital skills but don't necessarily have digital confidence. And I think that's increasingly the case when we ask people to use difficult technology in healthcare. The other thing I would say is that I'm not sure we've always designed healthcare technology to be user-friendly and be intuitive in the same way that other consumer apps have managed to make that work. And so I think of the classic example of I'm sure I won't get in trouble for this, but Can I
step in? Can I ask you specifically about WhatsApp?
Yeah.
Because WhatsApp, we know, is being used by medical staff. There is no doubt about it. It is being used. We know that the rules are that if you use WhatsApp, you shouldn't transmit details which identify your specific patient. But at the moment, it does seem that the NHS has accepted a little bit that you can exchange messages with WhatsApp. Is that still the case?
So there's guidance you can see the national guidance on WhatsApp on the website. You can easily find it. I think whenever people are whenever you see, it's a bit like, you know, when you go, when you're going across a park with your kids, right? And you see that there's the paved path here and the paved path here, and always there's the muddy strip here, which is the route people actually take. And I think whenever we see lots of people using consumer tech to do something that medtech should be doing, that's a recognition that we've got it wrong. And actually what we need to do is find safe and secure ways for people to share that messaging, rather than needing to kind of cut across the grass and tramp themselves in the mud. But the national information is there, it's available. We follow those policies in both UHL and UHN. But I recognise that, like, as long as there's an easy path to take, people will take it. And I think it's our job as digital professionals to make that easy path the safest path as well.
Well, I'd like to say a sincere thank you for being so open, being so honest with us, and admitting that you've made mistakes.
Yeah.
We don't often get people talking to UKDHC and saying, we've made mistakes, and these are the mistakes we've made. So what a wonderful presentation this has been. We are so grateful to you. Thank you very much for joining us. And good luck with your future career, which seems to be going upwards at the moment.
Thanks, Prof.